Hello everyone, we are pleased to present our research on hyperthermia treatment in biological tissues. This project is a collaborative effort between Jacob, Alberto, and myself, Osama. Our presentation focuses on how controlled hyperthermia is utilized as a medical treatment, particularly in targeting cancer cells, and the theoretical and computational framework that supports its application. To guide you through to our discussion, we have organized our presentation into six main sections. Number one, introduction to hyperthermia treatment. Number two, theoretical background, methodology, COMSOL multiplex module results, and the conclusion. With this roadmap, we aim to provide a comprehensive understanding of hyperthermia as a therapeutic tool and theoretical practical consideration. Now let's begin with the introduction of hyperthermia. Hypothermia refers to the controlled elevation of tissue temperature to a therapeutic range, typically between around 39 degrees centigrade to 45 degrees centigrade. Historically, first clinical application dates back in 1891, where the heat was introduced using extracts of Stropocus pyogenes. Over the years, hypothermia has evolved into a sophisticated treatment technique, particularly when used in conjunction with traditional cancer therapies like radiation and chemotherapy. The primary mechanism of hypothermia involves increasing the reactive oxygen species within the target tissues. This increase promotes the damage of circular structures, making cancer cells more susceptible to destruction. Hypothermia can be applied using four distinct methods: electromagnetic waves, such as radio frequency and microwaves, to penetrate and heat tissues. Number two, focused ultrasound, which delivers precise energy to target regions. Hyperthermic perfusion, used for internal organs by circulating heating fluids. And the last, conductive heating, where heat is transferred through direct contact. Each method is chosen based on the treatment area and the specific clinical requirement, ensuring precision and minimizing damage to surrounding healthy tissues. Now we discuss Penne's Bioheat equation, a critical mathematical tool for modeling heat transfer in biological tissues. Developed by William Penne in 1950, this equation revolutionized the way of researchers and engineers understand transient heat condition in living tissues. The unique aspect of this equation lies in its consideration of heterogeneous and anisotropic nature of biological tissues, which differ greatly from homogeneous materials like metals. This equation incorporates the three factors. Number one, heat generated internally, such as from metabolic activity. Number two, heat transfer through blood perfusion, as blood circulates heat throughout the body. Number three, external heat source applied during the treatment like hypothermia. This model is a fundamental of ensuring that heat is applied precisely and distributed in a way that maximizes the therapeutic benefits while protecting surrounding healthy tissues. Moving to a next part, which is the applications of Penny's equation. Penny's equation has a wide range of applications in the medical field. For example, it is used to design and evaluate hypothermia therapies by understanding how heat spreads through tissues. Clinicals and determine the optical temperature range and exposure time to the maximize cancer cell destruction. Beyond hypothermia, this equation is also critical for studying thermoregulations in humans, how the body maintains its temperature balance under various conditions. Additionally, it also plays a role in developing thermal therapies for pain management and injury recovery. Nowadays, engineers and medical professionals rely on Penny's equation to create devices that deliver precise heating for therapeutic process. Through these applications, Penny's equation serves as a bridge between theoretical science and practical medical innovations in the modern world. Now, let's shift our focus to the Arrhenius equation, another vital component of our study. This equation, developed by Swedish chemist Svante Arrhenius in 1899. This model the damage caused by the heat exposure over the time. In hyperthermia treatment, it helps to quantify the extent of thermal injury to the tissues. This model is having two key concepts. Number one, activation energy, which represents the energy required to initiate tissue damage. Number two, Boltzmann distribution, describing how heat energy is distributed among modules. This equation provides a way to predict how long a tissue can safely tolerate heat exposure and temperature threshold beyond which irreversible damage occurs. This predictive capacity is essential for tailoring treatments to specific patients and ensuring safety. Now we move towards the application of Arrhenius equations. The Arrhenius equation has a versatile application in both clinical and research setting. In hyperthermia therapy, it is used to model thermal ablation where tissue is intentionally heated to destroy cancer cells. It also aids in assessing thermal injuries such as burns by quantifying the severity of damage over the time. Beyond the human tissue, the equation finds use evaluating heat damage to biological materials like implants or surrounding tissues in medical procedures. It even has a pharmaceutical application, such as you can say that modeling the thermal stability of drugs. This helps predict drug shelf life and storage requirement under various conditions. In exchange, the Arrhenius equation provides a scientific framework need to be balanced, efficiency and safety across the variety of thermal applications. This concludes my part of the presentation. I will now hand it over to Alberto, who will be discussing the methodology and computational tools we employ to further study the hyperthermia treatment. Thank you.
Thank you, Sama. Now, for modeling hyperthermia treatment. One way to model hyperthermia treatment in cancerous tumors is by using a four-arm electrical probe as shown in the image to the right, where the outer cylinder is assumed to represent the human liver. The thin cylinder in the middle is the representation of the trocar that contains the trocar tip and electrodes. And lastly, the cylinder to the right represents an artery in close proximity to the trocar. The purpose of this artery is to scrutinize the effects of heat convection as it pertains to the trocar/tissue damage. The four-arm electrical probe method induces a controlled electrical current to the localized affected area that heats the malicious tissue to a critical temperature, which serves to eradicate cancerous cells. Our team decided to model this process in COMSOL Multisim, which is a powerful simulation software platform which is used for solving complex physical phenomena across a wide range of engineering applications. The aim of this simulation was to capture the essence of hyperthermic treatment in a simplicity model of the human liver using a four-arm electrical probe and scrutinizing the effects of heat transfer, distribution, and thermal damage using the fundamentals of Penne's and Arrhenius equations. All this was possible with the use of COMSOL Bioheat transfer and electrical current interface, as it is capable of incorporating Penne's and Arrhenius equations to evaluate the heat distribution of thermal damage effects and effects respectively. For the assumptions and parameters, to model this in COMSOL, our team made the following assumptions. As already discussed, for simplicity, cylinders were used for the representation of liver, trocar, and blood vessel. Additionally, given the fact that water content of blood is 90%, our team neglected the 10% content of electrolytes in blood, which account for potassium, chloride, etc., and used 1,000 kilograms over meters cubed as the density of blood. With similar principles, the relative permittivity of blood and all other components in this simulation were considered to be 1, which referred to a material relativity permittivity being equal to that of free space, or in other words, neglecting the significance interface of the electrical field. The initial boundary conditions of temperature was considered 37 degrees Celsius, which is roughly the average temperature of the human body at 98.6 Fahrenheit. The electrical current voltage was chosen to be 30 volts. The blood perfusion rate was considered to be moderate at 0.0064 1/seconds, and the time taken in consideration was 10 minutes. For all other parameters assumed, they can be seen in the table to the right. For the material properties, touching bases in the material properties used in this model, our team utilized the material library from COMSOL to apply to the distinct material characteristics. For example, liver parameters for electrical and thermal conductivity that were chosen are shown in this slide to be 0.333 Siemens per meter and 0.52 watts over meters Kelvin, respectively. As previously mentioned, the permittivity was assumed to be 1. Similar for blood parameters, the electrical and thermal conductivity were chosen to be 0.667 meters per Siemens per meter and 0.667 watts over meter Kelvin, respectively. And other factors were gathered from COMSOL library. As it can be noted, these values were typically for the respective materials and represent a moderate ability to transfer heat. For the computational mesh, right, due to the ability and flexibility of the tetrahedral computational mesh, this mesh was determined to be optimal for the simulation, as it provides the structural and simplicity and refinement for such shape, and it can be applied for biological tissue. The image to the right highlights how this was applied to our model. Now that we have talked about the assumptions and parameters taken in consideration for our model, let's dive into the results. The illustration to the right shows the temperature distribution at 10 minutes after inducing a voltage of 30 volts to the system. The temperature ranges can be seen in the bar to the right, where the temperature indices are shown in degrees Celsius. The maximum and minimum temperature are observed in the model that were observed in the model were documented to be 137 degrees Celsius and 37 degrees Celsius, respectively, even though the maximum temperature was above the ideal temperature of hyperthermia, which Osama discussed to be around 40 to 45 degrees Celsius. It does serve to illustrate the critical effects of temperature while undergoing hyperthermia treatment. As temperature above these normal ranges of 40 to 45 can cause irreversible tissue damage. So based on the chart, it can be seen that the maximum temperature is concentrated at the surface of the thoracore, where the electrical potential is the greatest. We can also observe the inverse correlation of temperature versus distance, as temperature decreases as the distance of the thoracore increases, once again showing how heat is dissipated to the surrounding. Similarly, the temperature versus time can be highlighted in the chart to the right, where the blue line indicates how time changes over time, at an observed location above the trocar electrodes, which is approximately 0.3 millimeters away from the x-axis. As the chart illustrates, the temperature exponentially increases in the first couple of minutes until it reaches a steady state of approximately 123 Celsius at the end, which is at the end of the 10 minutes. So now that we have observed the temperature how temperature dissipates along the biological tissue, we can start examining how this relates to the tissue damage. The image to the right highlights the fraction of damage of 3 different locations in close proximity to the probe over time, where the fraction of damage of one indicates complete thermal damage of the tissue. The blue line uh, indicated to be at the closest location at approximately 4 millimeters away from the trocar electrodes, which is previously shown containing the greatest temperature. As it can be observed, the closest distance to the trocar will have the greatest temperature. Thus, it indicates a thermal damage of 1. in less than a second. The green line uh, indicates a second point a little further at 12 millimeters from the electrodes, and therefore it reaches a value of thermal damage of 1 in approximately 2.5 seconds as seen in the image. Similarly, we can see the red line, which is the furthest point around 20 millimeters away from the electrodes. Uh, this one only reaches up to zero point 0.4 thermal damage, as it can be seen in the chart. With this, we can conclude that temperature and thermal damage are directly proportional. As temperature increases, thermal damage will increase. And then is indirectly proportional to distance, because as we are far away from the trocar, right, temperature decreases and therefore our thermal damage decreases. To further illustrate the fraction of tissue damage, let us observe the chart to the right, where we can see the volumetric representation of tissue damage in the X and Y plane. As highlighted in previous slides, the fraction of tissue damage is the highest closest to the trocar electrode, due to the temperature being the greatest in this area. At approximately 60 millimeters, we can start observing that the fraction of tissue damage is decreasing. But nevertheless, it can be noted that the fraction of tissue damage is non-zero at all locations. That means that at the boundary conditions or at the boundary of the surface is we still experience some type of tissue damage, but it is super small compared to the one closest to the electrodes. And this is due to the dissipation of heat in the surrounding. Lastly, our team wanted to highlight the influence of the artery when it is in close proximity to a trocar. As it can be seen in the image, initially the artery was chosen to be 33 millimeters away from the trocar center. We did this in the heat distribution at 40. With this, we highlight the distribution uh, of heat at approximately 43 degrees Celsius, as it can be observed in the image. We have a symmetrical volumetrical change based on the center axis of the trocar, despite the convection from the artery. Therefore, it was concluded that the artery has no influence in the heat distribution, thus neglecting the convection heat transfer. So in this case, we can see that the overall shape is symmetrical based on the x-axis, so we can neglect the influence of convection based on the artery. Just to scrutinize a little bit between that image and this one, we wanted to further demonstrate how the effects of moving the artery closer to the trocar center will influence its shape, right? So the results are illustrated in the image to the right, which simulates with similar parameters from above, just changing the proximity to the artery. Thus, it was observed that the heat distribution was influenced due to the convection boundary condition. And this is due to the artery being closer, causing this boundary condition to increase, resulting in an asymmetric volumetric change, highlighting the importance, which this highlights the importance and the significant influence of boundary conditions. This concludes the results portion of our assessment. Now I will let Jacob continue with the conclusion. Thank you.
Thank you, Alberto. So I'll go into some conclusions. So the process of executing the simulation highlighted some important implications for local electromagnetic hyperthermia treatment of cancerous tumors. The first major takeaway is related to the design of the trocar. The trocar tip geometry, material selection, and placement within the tissue all have significant influence on the resultant temperature distribution. In the simulation, the trocar tips were distributed symmetrically about the X and Y planes of the trocar. However, the geometry may be altered to focus heat in a specific area or direction if desired. Another major implication for therapy is that the proximity to major perfusion sites has a significant impact on the temperature distribution, as Alberto shared. In the simulation, the artery was far away from the trocar and therefore had negligible impact on the distribution of thermal damage. However, when the artery was moved closer, the perfusion at the artery altered the distribution of damage near the boundary. This demonstrates that great consideration should be given to the location of the trocar within the tissue during treatment planning, specifically to the proximity to major perfusion boundaries. A final major implication for hyperthermia treatment is that greater therapy lengths continually increase thermal damage fractions outside of the tumor volume. For that reason, treatment simulations should be modeled as accurately as possible to approximate the minimum amount of time required to achieve the desired damage in the tumor, so the damage to the surrounding healthy tissue can be minimized. So next I'll talk about some limitations of Penne's equation. So Penne's equation comes with inherent limitations that must be considered in its application. The first limitation is that it assumes a uniform perfusion rate. So this isn't always accurate with the real world. Perfusion rates can vary with time as well as location within the tumor. So that's a source of some inaccuracies within Penne's equation. Another limitation is that it assumes blood equilibrates to the temperature of the surrounding tissue, which means that it doesn't accurately account for large arteries or high perfusion rates where the blood may not actually equilibrate with its surroundings due to high blood flow and strong convection effects. Additionally, the equation assumes constant metabolic heat generation. In real biological systems, metabolic heat generation varies with time, activity of the person or of the subject, as well as environmental conditions. Finally, the equation assumes homogeneous tissue properties. This is often not completely true, especially for tissues such as bone, where the properties can vary significantly throughout its volume. So all of these limitations should be carefully considered when creating models using Penne's equation so that the potential inaccuracies are accounted for. And then the same thing with Arrhenius' equation. It also has its own limitations. The first of which is limited temperature range validity. So at extremely high or low temperatures, the damage predictions don't account for other damage mechanisms that come into play or phase changes of the material. The damage is still just calculated only on the activation energy. So other approaches should be used at extreme temperatures instead of Arrhenius' equation. The equation also assumes that the activation energy for thermal damage of the cells is constant, but this is a property that can actually vary with temperature as well as the rate of heat applied. So in other words, the energy required to completely destroy the cells changes depending on its environment. Another limitation is that cellular repair mechanisms aren't accounted for. Biological systems such as heat shock proteins exist, which can respond to heat and repair damaged cells. So estimations typically are conservative. Another limitation is that the damage rate follows first-order reaction kinetics. In other words, it assumes that the reaction rate is directly proportional to the concentration of the reactants. So this assumption allows for simplicity of calculation, but there is some inherent inaccuracy that comes with it. Finally, the equation focuses only on irreversible thermal damage. This means that it does not give insights into reduced cell function or reversible damage. For example, heat may partially damage a cell, but it may still retain some functionality and not completely die. So the Arrhenius equation doesn't consider these cells and only gives approximations of the percentage of cells completely destroyed. Then some suggestions for refinement of the model in general. So although the presented model is a sufficient tool for modeling heat transfer in biological tissues, there are opportunities to improve the model or improve the approach altogether. One area of refinement is the 3D model of the tissue structure that we used in our simulation. The geometry in the study was highly simplistic and was mostly made up of cylinders. At the scale that we were using it at, it likely has little impact on the results. However, more accurate modeling of the structures would lead to more confidence in the results at larger scales. For very short timescales, the Maxwell-Cattaneo model may actually be a better tool in place of Penne's equation. Penne's equation is based on Fourier's and is parabolic. So it assumes an infinite speed of the propagation of heat, which means that it's not compatible with the framework of relativity. So this leads to inaccuracies at very short time intervals. So for improved results, the Maxwell-Cattaneo model can be used instead, which is hyperbolic and includes a relaxation time term in the equation for heat flux. So this means that the Maxwell-Cattaneo model is compatible with the framework of relativity and can be expected to deliver more accurate results for smaller timescales. Finally, a thermal dose model can be used alongside the Arrhenius model to cross-check the damage predictions. As discussed previously, there's multiple limitations to the Arrhenius equation, and conjunctive application of a model such as CEM43 can add confidence to the damage predictions. So CEM43 is a normalizing method that's also widely used that expresses an equivalent exposure time at a reference temperature of 43 degrees Celsius to estimate the extent of cell damage. And then finally, some final remarks on the whole study. Despite their limitations, Penne's Bioheat transfer equation and the Arrhenius equation for thermal damage can sufficiently model thermal distribution and damage in most applications of hyperthermia cancer treatment. COMSOL is a very capable tool for this task and enables efficient application of these mathematical models to transient three-dimensional problems as they're directly built in. Careful considerations must be made by engineers and medical professionals when constructing hyperthermia simulations because biological structures are very complex. So to minimize risk to the patient, all the limitations and assumptions that were discussed that are inherent to both the Penne's and Arrhenius models must be understood and carefully accounted for. And with that, I will conclude our presentation. Thank you for your time.